Whoever is going to join will join. Let's start. So the four topics we'll just discuss would revolve around peritoneal dialysis, CPR, NG tube feeding, and intramuscular injections. Why these topics are necessary is that, fine, you're a caregiver, you're not a nursing personnel. There are some homes that you may get there and find that the patient is on peritoneal dialysis. Peritoneal dialysis is like a kind of kidney care for someone with end-stage kidney failure. It's different from hemodialysis. Hemo is blood. So blood dialysis, those ones usually are connected to machine. Peritoneal dialysis many times is done by the patient, but if it's a patient who has a caregiver, you may be the one that is recruited to do that. So it's important to still have some basic understanding around it. What I will kindly request and kindly suggest is that these topics, please pick them up and try and watch YouTube videos that explains or shows how the procedure is being done. But when you come to the hospital, if we happen to have a patient having peritoneal dialysis done, then you will get to see it. But I know all the other ones, you will see them done: intramuscular injection, NG tube feeding, and the others. So I will just go through the slides briefly. I will not dwell on each slide points so that we'll be able to cover the intended topic. So peritoneal dialysis is the process during which the peritoneal cavity acts as a reservoir for dialysate, and peritoneum would serve as a semi-permeable membrane across which excess body fluids and solids, including uremic toxins, are removed. So the peritoneum, in persons who would have peritoneal dialysis, usually they have a peritoneal catheter inserted. This is the catheter inserted going into the peritoneal cavity. The peritoneal cavity is the space that houses the abdomen. After you've taken out the abdominal wall, the abdominal muscle, the next place you get to is the peritoneal cavity. It's just a free space. It's different from the intestinal space. So it's a free space that the dialysis fluid can be run into. Then the waste product that is in the patient's blood seeps into the dialysis fluid, and then it is drained out. So it's like you're washing the blood. That's the simplest way I can explain it. Essentially, you are dialyzing. That's the medical term for it. So persons who would need peritoneal dialysis are usually patients with chronic kidney disease, or well, they are all patients with chronic kidney disease who, for one reason or the other, cannot have hemodialysis. Hemodialysis is the one that happens on the machine, that usually you connect the patient to the machine and then carry out your dialysis procedure. So some reasons that some patients will choose to have peritoneal dialysis is that it's easy to learn. Even you as the caregiver, uneducated patients, they pick it over time and they do it seamlessly. So it's easy to learn. It can be done at home. So the patient will not have the stress of coming to the hospital twice a week, because those who are on hemodialysis, they will come to the hospital minimum twice a week. It takes that burden off them. Then it helps to control their blood pressure better. So even those who are at risk of having their blood pressure crashing, if they place them on hemodialysis machine, if they have peritoneal dialysis at home, there isn't much concerns about it. Now, the thing you want to keep in mind, like I said, when you come over to the side of the hospital, you also still see those things, is that because it is done at home, the risk of infection is high. So the most important thing that the caregiver and the patient want to keep in mind is to maintain sterility. So you wash your hand, you disinfect your hand, disinfect the tube, disinfect everything as much as possible. You cannot be too clean, you cannot be too hygienic for a patient who would have any clinical procedure. So this is like a drawing of still the same thing I'm trying to describe. This is the supposed patient sitting comfortably and reading a book. So you can see the fresh dialysis solution that is being passed into the abdominal cavity. Usually once it's passed, we allow it to sit for some hours, between 2 to 4 hours, so that the waste product within the system can be drained into the dialysis fluid. Then you now drain it out through the drainage bag. But my own network is pretty stable here. Maybe it's the network on your own side, but it's very, very stable on my side here. Let me increase the volume. Okay, volume is at the highest. So the network is pretty stable here. Perhaps it's on your own side. So still on the peritoneal dialysis, this is still another one. You have the tube going into the patient's peritoneal cavity. You have the dialysate, which is the dialysis fluid that is run into the space. Then you wait a little, you want to drain out those contents or the waste products in the patient's system. And after a number of hours of waiting, we call it indwelling period, you then drain out the waste fluid. Then some patients can have automated dialysis. Some patients can have automated peritoneal dialysis such a way that there's a machine that does all of those necessary things. They may even be sleeping, the machine runs the fluid into their peritoneal cavity. While they're also still at sleep, the machine would also do the drainage for them. Okay, I think by and large, that would summarize the important thing we want to say about peritoneal dialysis. Mrs. Jejelowo, I don't know how much of what I said you heard, in case you have a question, so that we can take it before we go briefly to the next one. Mrs. Jejelowo, how much of what I said did you hear? Okay, so we'll briefly discuss intramuscular injections. Again, as a caregiver, you may be requested to give intramuscular injections, especially for a patient you take care of at home. So we'll discuss the theory here. You get to see the hands-on experience when you come to the hospital. The most important thing is the site. After having confirmed the patient you want to give the injection to, the dosage of the injection, the name of the injection, those confirmations must have been made. So what are the sites where injections can be given to? It can be given into the dorsogluteal site. The dorsogluteal site is the buttocks. But each buttocks, we envision a division into 4 quadrants. So the upper outer quadrants, if you can see, this is someone placing the hand imaginarily on the buttocks and then dividing into 4. So the upper outer quadrants is where the injection goes to for intramuscular injections. Then you can also give it into the deltoid. The deltoid is here where you have the bulge of the deltoid muscle. The intramuscular injection can also be given into that location. Now, in situations where you have to give a baby an injection, this is the picture of the baby. So it can be given into the lateral side of the thigh. The muscle there is called the vastus lateralis. This line where you have drawn here, the injection can be placed into here. So in case your patient is a child or an adult, any of those locations can be used to administer the injection. Then for the adult, you can also still place on the thigh. On the thigh, you're aiming for these groups of muscles. Now, importantly, whether you're giving the injection into the gluteal space, or you're giving it into the thigh, or you're giving it into the deltoid region, wherever you may be desiring to give the injection, you want to be sure that your needle is at angle 90 degree. Once you tilt it differently from angle 90 degree, chances are the needle will not be able to get deep into the muscle. So it's important that the angle of your needle is at 90 degree to the skin of the location where you want to administer the intramuscular injection. Now, for intravenous injection, for most persons that you would need to put an intravenous injection for, many times the IV cannula would have been inserted ab initio. So all you would have to do is to constitute the medications and administer it for your patients. But again, like I said earlier, when we're talking about peritoneal dialysis, for every clinical procedure, the risk of infection hangs around. And for intravenous injection, there's the risk of thrombophlebitis, which is inflammation of that vein that is being used for the injection. So it could get inflamed, it could get swollen, you could have formation of blisters around there. For prevention of infection, what you want to keep in mind is that you maintain sterility. Are you talking to me?
Ma.
Are you talking to me?
Yes, ma. Yes, now my network just came. So even I'm outside now. Please, ma.
No.
Hello.
Yes, I can hear you.
What module are we, ma?
Okay, you know we are currently doing module 15, 14, 13. But we have all the lectures for all the other modules. So what I am teaching now is module 15G, intramuscular and intravenous injections. All the other ones, we had taught those ones ahead and we had hosted them on the YouTube.
Yes, I've seen those ones. I've seen those ones.
Yes.
Okay. Those are your big
Can I go ahead?
Okay, ma'am. Yes, ma'am.
Okay. Okay, so like I said earlier, for intravenous, just to take the normal precautionary measures. Have your hands washed, be sure the needle and syringe is sterile, and do the normal hygienic things you will do. But for intravenous injections, if you have to give your patients intravenous injections and you find that the hand is swollen where the cannula is inserted, or the patient is screaming of pain, you may want to stop administering such injection, because the downside or the complication that may follow that is thrombophlebitis. That's when the veins will get inflamed. Some of them could rupture, then there is swelling. If it gets so bad, there may be pus and further complications down the line. So if you get sent home with a patient to administer intravenous injection to, you want to keep those two in mind, especially. Venesection cut down procedures. These are usually done in the hospital for someone that there's no way to get a line for, that has particularly difficult lines. So usually they would make a cut down. It's a surgical procedure done anyway. They'll make a cut down into the vein and then visualize the vein and insert a tubing inside. So to prepare materials for vein cut down, these are the kind of things that will be used. Now, as a caregiver, this would not happen in the house. This may probably happen to your patient who is brought to the hospital and needs to have a vein cut down done, or if you happen to work in the hospital and you're privileged to see something like that. These are the things that will be prepared to have the procedure done. Okay, I think by and large, that may be all for intravenous and intramuscular injections. I said we're going to just go through them briefly and see what we can learn in the short period. Mrs. Jejelowo, do you have any question in the meantime before I go to the next slide? So now for urethral catheterization, again, like I said earlier, some of your patients may need that done at home. Most persons would have been catheterized from the hospital. They may just get sent home with the catheter. It's important to also know what the procedure entails, and so knowing what the procedure entails also gives you an objective understanding of what your patient is carrying when it comes to catheter. Catheterization is usually indicated for persons who have problem with urination, or for persons who had surgeries done and you don't want them to go up and down to pee and you're waiting for healing to take place. So for female catheterization, the urethra opening, that is where urine comes out from, is usually anterior, and the catheter is placed like so, with the balloon sitting within the bladder. And here is the same catheter for a man, with the balloon sitting within the bladder. So catheterization of the urinary bladder is the insertion of a hollow tube through the urethra into the bladder for removing urine. It's an aseptic procedure. Aseptic meaning it's a sterile procedure, and the equipment you would usually use are sterile equipment. So here you have the picture of the urethra catheter going through the penis into the person's bladder, and is secured to the thigh and drains into a urine bag. You have the same picture on the other side. So what are some reasons that a patient may need to have urethral catheterization done? If a patient has acute urinary retention, so urine is retained, is not coming out, the patient cannot pee, or when there's a need to collect some sterile urine specimen for investigation. And it could be to empty the bladder before the surgery, during a surgery, or after a surgery, or in situations where the patient is on strict urine output measurement and you want to objectively be able to assess how much urine is this patient making. Okay, so importantly, I just want to explain this because you may also have your patient having something called suprapubic catheter. Suprapubic catheter are placed on the lower part of the abdomen like so, and goes straight into the bladder. It's different from the one that comes through the penile tip and goes through the length of the urethra to get into the bladder. This is oftentimes placed in the lower part of the abdomen, in the suprapubic region, and then sits within the bladder. Okay, and I think that is summarily the little I have to share on urethral catheterization. So finally, now we go to cardiopulmonary resuscitation. Okay, nasogastric tube intubation and feeding. Okay, so what do you need to know about this? There are also some patients, stroke patients, who are sent home. Those are usually maybe hospice cases. Hospice cases are like end of life cases that for one reason or the other, they may not be able to eat through the mouth as we would all do. So for some of such persons may have a nasogastric tube inserted, and then feeds and medications are administered via such tubes. And there are also some babies that would need such. Babies that would need nasogastric tube feeding are usually retained in the hospital. But end of life cases, severe cases of stroke that are terminal may be sent home with NG tube, and then the caregiver has the instruction of administering feeds or medications. Those are usually end of life cases. But then if you have a patient in the hospital and you're a caregiver employed in the hospital to give those supportive cares, you may have a patient who is more alert, or maybe a patient who had a surgery and just a number of things that would require them to put a tube through the nose into the patient's abdomen. So that is what NG tube is. NG tube is nasogastric tube. Naso for the nose, goes through the nose, gastric to the stomach. So here is a picture of a nursing personnel feeding a patient who has a nasogastric tube in situ. This is the feeding syringe, and you can see him pouring the feed into the feeding syringe. What are some reasons for a patient to have nasogastric tube inserted? One, to provide adequate nutrition to patients who cannot feed themselves. You know, I said that earlier. To administer medications who would have problems swallowing, or to provide nourishment to patients who cannot be fed through the mouth. So persons who had oral surgery done and, you know, food is not allowed to go through that place, you can bypass that route by putting a tube through the nose down to the stomach. Or in patients who are unconscious, or a patient who is comatose, such persons may need to have NG tube inserted. Also in persons who have had head or neck injury, who have severe anorexia nervosa. It's a form of psychological disorder in which they have intense fear of eating. Or patients with increased metabolic needs, like those who had burns, if it's a significant burns to the skin, and patients with cancer. So nasogastric tube is also called Levin's tube. This is what the tube looks like. So in preparing to insert a nasogastric tube, some things that you would want to get together will be, of course, the nasogastric tube itself, the feed or the food or the liquid or the medication that will be passed through the nasogastric tube. Then a graduated container could be a syringe, just so that the graduation is just it has calibration, it has volume, so that you know what it is you have administered to the patient. Then you need water in a container and you need stethoscope. So here is a picture of a patient with nasogastric tube in situ, and you can see what looks like milk, could be medication that is being fed into that via the tube into the patient. So this is a graduated container, such that if you give the patient 120 mils, the container is calibrated and you can see what it is that you give your patient factually. So now, if you need to feed a patient via the nasogastric tube, what are the things that you want to keep in mind? One, you want to identify your patient. If that's the only patient you're caring for, there wouldn't be such confusion. But supposing you work in a large hospital where there are like 4 or 5 patients on nasogastric tube, you have to confirm by name that this is the patient that you have the instruction to go and feed. And whatever it is you want to feed the patient has to be warmed. You can't bring something very cold via the patient's nasogastric tube. Reason is that if you take food through your mouth, chances are you will chew it up. The process of chewing it up warms it. But the NG tube, nasogastric tube route, nobody is chewing it up. So if you run something very cold, it will be quite jolting or very shocking to your patient. Then have your hands washed, have towels and Macintosh over the patient's chest because there could be a bit of spillage around. Be gloved to get it done. So you have to wear a pair of gloves. Then before you start, there's this thing we do, we aspirate. So you take out a bit of content from the stomach to see is there anything there or is it empty? And if it's empty, you then place your tube you place your feeding syringe into the nasogastric tube, and then you begin to pour whatever it is you want to pour into the syringe and wait for it to gradually go down by gravity. There's no pushing it down, it's gravity that will take it down. And when your patient is done, maybe when you're done feeding the patient or giving the medications, you want to close the tube, because if you don't close the tube, everything that you have poured inside will just pour back outside. And the materials you used, of course, you want to clean it and you want to elevate the head of your patient. Then you wash your hand, you document importantly. So I gave Mr. A 150 mils of pap and I gave so and so medication at 10 a.m. The next feeding may be by 2 p.m. 2 p.m. you gave Mr. B 200 mils of fortified pap and so medication. Documentation is important, is essential for such persons. Even if it's that they are eating food, but they're not eating it through the normal route. So it still has to be documented. All that I explained is the same thing that is inside this picture that I said earlier. So after washing your hand, confirming that the patient is the patient that needs to be fed, you warm whatever you want to administer to the patient. Maybe it's medication dissolved in water, or it is fortified pap or milk, as the case may be. And then you place your syringe into the NG tube and then pour the content and let gravity drain it. And when you're done with it, you want to give some fluid just to clear it out. And finally, you cap the NG tube. It's important you cap the NG tube. If you leave it open, all that you have given will just pour back outside. Okay, so I think that ends this presentation on nasogastric feeding. The final one we have is cardiopulmonary resuscitation. Please, do you have any question in the meantime before we go to the next one? Please, any question? Okay. So cardiopulmonary resuscitation is also called CPR. And if we break those words down, C, cardio, is for the heart. Pulmonary is lungs. Resuscitation is to recover. So persons that will need cardiopulmonary resuscitation oftentimes lost consciousness and the heart stopped, the heart wasn't beating. And such a patient may also not be breathing. So you have to do like artificial breath and heartbeat for them to be able to come around. So it's a technique of basic life support for the purpose of oxygenation to the heart, to the lungs, and to the brain, until and unless the appropriate medical treatment can come and restore the normal cardiopulmonary function. Supposing you are working with your patient and the patient just slumps and passes out. and is not responsive, and you feel for the pulse and you couldn't feel a pulse, the next thing you go to is cardiopulmonary resuscitation, which is CPR. I have a video we'll watch together when I'm done that better explains what it is I'm trying to teach. So it's a series of steps that is used to establish artificial ventilation and circulation in the patient who is not breathing and has no pulse. If your patient has pulse and is breathing, such a patient does not need CPR. It could just be that the patient had a syncopal attack, the patient fainted. Once you lie the patient down, many times they will come around again. The ones that will need CPR are the ones who do not have a pulse or who is not breathing. So the purpose of CPR is to restore cardiopulmonary function and to prevent irreversible brain damage. In that period when the heart is not pumping and the patient is not breathing, oxygenated blood is not being carried to the brain. If oxygenated blood is not being carried to the brain, the patient can have brain death. So you're doing CPR is you pumping blood to the brain, and the artificial rescue breath that is given is also to ensure a bit of oxygenation goes to the brain in that period. So indications for CPR are a patient who has cardiac arrest, a patient who has respiratory arrest, or a patient who has a combination of both. So cardiac arrest is the loss of cardiac function, breathing, and loss of consciousness. So the heart stops to breathe. So how does CPR work? The air we breathe in will travel to our lungs, where oxygen is picked up by our blood, and then the blood will be pumped by the heart to the tissues and to the organs in a normal situation. Now, when a patient has cardiac arrest, maybe it's due to heart failure in the adults or elderly, or an injury such as near drowning, someone falls in water or in a bucket of water and almost gets drowned, or a severe trauma and any kind of situations that can make the heart stop beating. Once the heart stops beating, the oxygenated blood is not being pumped around the body, and importantly, is not getting to the brain. So the patient is at risk of brain death. So CPR may save your patient's life if it's performed properly, and especially if it is commenced within 4 minutes of cardiac arrest, within 4 minutes of the heart stopping. Your patient will have about 40% chance of survival. So what are the things you will need if you want to do CPR for the patient? You need a hard, flat surface. And other than that, if it happens at home, you don't need any other thing. You need your hands and you need your mouth to be able to give the rescue breath, the hand for the chest compression. So this is like a picture trying to explain it. You find that the patient is not breathing, call for help immediately. And while waiting for help, you start the chest compression to buy time. As you're giving the chest compression, you would also be giving rescue breath till some other teams of medics will come around to be of help for you. What that means is if you are in the house with your clients that you take care of, and the patient passes out and is not breathing and there's no pulse, first thing is call for help. Second thing is you begin CPR with the hope that in the period you're doing CPR, help will arrive. If you live in countries where things work, you call 911. If you're in Nigeria, you get a relation to go and get a vehicle to move the patient to the hospital. So how do you recognize a patient that will need CPR? You want to assess for unresponsiveness. Is this patient responding? You check the victim for a response. You want to shake their shoulder a bit and ask, are you all right? You may even ask, if you can hear me, squeeze my finger. But if you don't then get any response and you can't feel any pulse and the patient is not breathing, and you can't feel pulse even in the carotid, in the neck area, for up to 4 seconds, then you begin CPR. CPR is giving an acronym of CAB. So you do chest compressions, you tilt the airway, and you give rescue breath. I have a video that explains that. So this is the technique of the chest compression that you would want to give the patient. This is how you would want to interlock your fingers, just so that you can get the maximum force to push the chest. And you're giving 30 chest compressions to 2 rescue breaths. Okay, so now we would watch the video that explains this so the video that explains the CPR. And for the second video that we would be watching, this is it. Okay, with that, we come to the end of the lecture. Do you have any question, please? Any question, please? Can you hear me?
Yes, yes. No, ma.
No question, okay. Thank you very much. I'll send the link. I know the network was quite, maybe poor on your side. My own network was very good, but I have it recorded. I'll send the link so that you can also go through it. Enjoy the rest of your week.
Ma. Thank you, ma. All right, ma.
Very much, okay.